Welcome back to my session. We were talking about hernias. So we will continue with the hernias. We are going to start with the presentation of how a hernia presents, and then as we go sequentially, we will talk about inspection, palpation, percussion. Then we will talk about the investigations. Finally, we will go towards the treatment, and then we will move on to our next topic. So in today's topic, how will a hernia present? That is what we have to see. Now, depending on the stage of the hernia, what stage is the hernia in, you will have presentations according to that. By that, I mean that as we discussed before, we had a stage of reducibility, then irreducibility. Then we had obstruction, strangulation, and inflammation of a hernia. So, if a hernia is reducible, and you might not find any symptom at all, just a swelling which is coming and going with cough or with straining and raised intra-abdominal pressure. So, irreducibility, you might start experiencing pain. You might, because it's something that is there, it's lying there, it starts to bother you and you want to put it back. So somehow you manage to reduce it. But if you cannot reduce it manually, then it becomes irreducible. Then what happens? Slowly and slowly you have a bowel inside it as a content. And in this bowel, there is some gurgling sounds which are coming in it. So that's how you see whether you have something inside that hernia. Sometimes you might not hear a gurgling sound. When you hear a sound there, it's more like a enterocele. And when you don't hear a sound, it's just like a firm mass sitting there. It might be the omentum, so that becomes the omentocele. So then what happens? As we progress, this hernia then becomes obstructed, and then there is a depletion of the blood supply in this hernia. When that happens, what do you get? You start having changes within that. That's pain, severe pain you might get with that. Alteration in bowel habits. If there is an obstruction, then strangulation, the bowel habits will start changing slowly, but then it is sufficient to take you to a hospital and get, admitted there, and the procedure starts for the operation. So usually and wisely, people know there is a hernia. Up to the stage of irreducibility, they have usually presented to a surgeon to find out what is happening. And that is what I always suggest. Then finally, depending on the stage of, suppose there is any inflammation, any appendix that is getting involved in it. Like we'll talk in a later time, we'll talk about sliding hernias. So there's some other organs may be involved in it. So according to that, you will experience symptoms. You might also experience pain not only at the site of the hernia, you might experience pain lower anterior and the lower surface of the thigh. So that might be the anterior surface of the thigh because of the ilioinguinal nerve which is present there. That supplies a lot of places. Base of the penis, then it supplies the anterior surface of the thigh, then it also supplies the lower half of the inguinal region. So this is wherever, and if you remember, I told you in the previous video about the content of the inguinal canal is the ilioinguinal nerve and the genital branch of the genitofemoral nerve. So wherever you get this ilioinguinal nerve, there's impaction out there, there's a pressure on it, it gets compressed. So what will happen? You will get this pain, referred pain, according to where the distribution of the nerve is. So accordingly, you might have some variable symptoms which are coming as pain in that. Then you might have like nausea and vomiting. If there is obstruction, you'll start having nausea, vomiting. You'll not be able to pass motion, so that is constipation. So these are the basic presenting symptoms of what we are talking about. Okay? So this is how you get a feel in the history that where the hernia is right now and what is happening. Then we move on. We can talk about what are the types of the hernias. So basically there are 4 types of hernias which we have seen usually. There's a classification on the types of hernias. And then there is type 1, type 2, type 3A, type 3B, type 3C, and then type 4 type of hernias. Now what is the staging? How do we stage these hernias? How do we classify these? So coming to the types of the hernias now, type 1, type 2, type 3A, type 3B, type 3C, and type 4. Type 1A is where the internal or the deep inguinal ring is intact. Type 2 is where the deep inguinal ring or the internal inguinal ring is enlarged. I hope you remember from the previous video that you have studied superficial inguinal ring and deep inguinal ring. Deep inguinal ring, which is 1.25 centimeters above the mid inguinal point. So now we come to type 3. So type 1 is normal internal inguinal ring. Type 2 is enlarged internal inguinal ring. Type 3A is your direct hernia. Type 3B is your hernias that have associated like a sliding hernia or pantaloons hernia, which are also called as pantaloons hernias are also called as Romberg's hernia or saddlebag hernia, or even a dual hernia, in which you have a component of a direct as well as indirect on either side of the inferior epigastric artery. So then you have type 3A is your direct, B is your saddle pantaloon type, C is your femoral hernia. So type 3C is your femoral hernias, and type 4 are your recurrent hernias. So if we understand this basic simple classification, you know exactly what kind of hernia you are having and how you are going to go ahead. Then we come to the inspection. It is always advisable to examine a hernia patient in a standing position. Okay. And when you are examining a hernia that time, ask the patient to cough. When you ask the patient to cough, obviously there is an increase in intra-abdominal pressure which will cause the hernia to bulge, and you know exactly where the hernia is. So just remember that if the hernia is above and medial to the inguinal region, that is a inguinal hernia. If the hernia appears to be below and lateral to the inguinal area, that is your femoral hernia. Okay? So this is how we need, without even trying to touch the patient, you can make out which type of hernia it is and what is happening there in the groin region. Now we come to the palpation of a hernia. So you have a lot of modalities in how you can actually make out. It's very simple. These tests are very simple. You have tests like finger invagination test, then you have deep ring occlusion test, then you have Siemens technique, then you have other techniques, but this is the simplest ones which we can talk about. Firstly, you have the finger invagination test. So in that, you have to clear the scrotal region and put your finger where these tests have to be done by medical students, okay, and qualified people. So please don't attempt it if you are not into the field. So what do? We can put gently your index finger at the area of the superficial inguinal vein and ask the patient to cough. So if the patient's hernia appears to be on your tip, which means that the hernia is coming from the inguinal canal. If it hits the tip of your finger, so that means it's more likely to be an indirect hernia. Whereas, if you feel that the impulse that has come onto your finger is coming onto the pulp of your finger, so that becomes a direct hernia. That means it's coming from the hasselbach area and it's coming through the wall and not through the inguinal canal. So this is the first basic test which you can find out and it's quite helpful. You can know it whether it's a direct hernia or it's an indirect hernia. Secondly, we have the Siemens technique, in which you put your index finger over the deep inguinal ring, then ring finger you put on the superficial inguinal ring, and the third one you put it on your this ovalis, fossa, that to mark out whether it's a femoral hernia. So wherever you get the impulse, so that means that it is a direct, indirect, or it is a femoral hernia. Then you have obviously the deep inguinal ring. You occlude the ring 1.25 centimeters above the mid inguinal point. If the hernia appears even after the occlusion has occurred, it is obviously a direct hernia, not an indirect. So these are the basic types of palpation techniques in which you can make out whether the hernia is direct or an indirect hernia. Then moving on, then you come to the percussion. Sometimes the hernia, the swelling is a hyperresonant swelling. So if it is resonant, you can feel it, you can percuss it, and you can actually feel that there is something happening inside. Meanwhile, you have to check for the consistency also, whether it's firm, what is the swelling you are getting. To first get the feel of the swelling, whether it's, what is the consistency of the swelling. Then what is the temperature of the swelling? Is it inflamed or not? And then you move on. So then we come to the palpation, and in this palpation we talked about some techniques, and then we come to the percussion. Percussion hyporesonant, if there is this thing, then it's entrocele. If it is there, firm, and you cannot, most likely an momentum lying beneath that. Okay, so these are the ways you can make out what kind of hernia we're talking about. Then we need to know how to manage such a patient. 90% high specificity and sensitivity ultrasound is good enough. If you can't, then you can even do a herniography. And in that herniography, you can make out the hernia if required. Otherwise, you can also do a CT. This MRIs scans are also very good to find out. CT scans, obviously, MRIs. You can do whatever tests to find out what kind of hernia it is, how big it is, what is happening there. Even if the hernia is inflamed or anything, you can do blood counts to find out what is the level of infection there. And then as we move on, how will you manage, how will you approach to manage such a case? Reassurance, obviously there's nothing wrong. The patient doesn't want to get operated at that time, then you tell the patient that okay, you try using a truss if you can. It's a round structure that fits into the hernia area, and you can wear it as a belt. They used to wear it. It's a very old technique. And obviously if there is a hernia and then you have to do some, like you live on the top floor and you have to keep climbing stairs, going up and down, so put your hand there where the hernia is, and then walk. If you have a cuff, then you can put your hand there as long as it's not. But you should know that if it is becoming irreducible or if there is a lot of pain there, then you have to get it operated. So what are the modalities of treatment in that? There are a lot of modalities. So in the operative modalities of treatment, you have a tension-free Lichtenstein's hernia. Now this is a tension-free repair, very popular repair, even results better than laparoscopic. It's an open technique which is being used. So this is a popular technique which is used to repair a hernia. Then second you have shoulders repair, then you have Bassini's repair. These are the open techniques of repairing the hernias. There are a lot of techniques, I'm talking about just a few names here. Then you have operative modalities, operations laparoscopically. This laparoscopically you have this properitoneal repair which is called TAP. Then you have extraperitoneal repair which is called TEP. So these have their own advantages, but the growth curve is a little longer in case of laparoscopic surgery and should be performed only with surgical expertise even today. And but they have certain advantages of doing it laparoscopically. In that there is less bleeding, seromas, infections. But it is also said that if you have a unilateral repair, maybe the open or tension-free is better. But if you have a bilateral or recurrent repairs, the laparoscopic repair is much better. But this is all very technically subjective to the place you are getting operated in. Higher centers, it is very routinely to have a laparoscopic hernia repaired. So we have to remember that what kind of way are we going to get ourselves operated, and only then you should decide whether it is. Otherwise, I'm sure they will let you know on their own whether they would like to perform an open or a laparoscopic repair in this case, which is coming to them. But there are certain complications also of having a hernia repair. So what are the basic complications? Obviously, you can have infection, like you have to place a mesh inside to hold the hernia, and this mesh protects the internal abdominal structures from again herniating outside from the potential weakness and from the abdominal wall, and it also helps to strengthen the abdominal wall in a better way. So these meshes are basically polypropylene, and they have in all sizes. They come 6x6 or 9x6 or maybe 15 up to 15. So it depends how big is it. Like there is a giant replacement of the prosthetic sac. Sometimes you require surgery for that, and a large mesh is required in that case. So there are very different techniques which are used. It all depends how big is your hernia, where is your hernia, and what type of hernia you're having there. So also, as we continue, we can talk a little about the complications also, what can happen. So I was talking about the mesh. So sometimes you can have a mesh migration and folding of the mesh that can cause some kind of an obstructive kind of azoospermia picture also. Sometimes we have seen that, but it doesn't happen much. But there are other things that can happen, like erosion, adhesion, migration of the mesh, and then you have infection of the mesh. So, but if you give good, if required, antibiotic coverages and post-operative care, and all these complications can be taken care of. So usually the final call obviously is that what stage of hernia you are in, whether surgery is required at that stage or not, and how well you are after the surgery is over. So I can stop here now, and in the next session we're going to talk about a different topic altogether. So I like to take one big topic, like we talked about gallstones, and then I went on to a book. Then we now talked about hernia. Now after this, maybe we can spend some time talking about artificial intelligence. So I hope to see you there in the next session also. Thank you.